Good evening. Welcome to Dr. Twyman's Ask Me Anything. Every Monday, 6 p.m. Central Time, I help you guys reduce your risk of having heart attack and strokes. So welcome to those that have been here before. If you're new, I've been a cardiologist since 2012 and a doctor since 2002. So I've been doing this for a minute or so. So I don't always have all the answers, but I have a decent idea what it's required to reduce your risk of having a heart attack or stroke. And I do that every day at my practice, Apollo Cardiology in St. Louis, Missouri, where I work with patients all over the country and actually the world at helping them reduce their risk factors. So it's on the telemedicine circuit today, talking to people from Kentucky. Let's see, where else are people from? Somebody from Missouri, somebody from South Carolina today, I believe. So if you're interested potentially ever working with me, I do have some availability, but this is not for FOMO, but it's very likely I will close my practice this year to new patients because I usually only see about 200 new patients a year, and I'm getting quickly at that limit for the year. It is just myself and two great assistants who run Apollo Cardiology, so we're a lean, mean team, but we do a great job with the bandwidth that we do have. So if you're potentially interested in working with us, go to my website, drtwyman.com, and fill out an application, and one of my team will contact you. Two other pieces of housekeeping is that the Canyon Ranch Retreat is October 29th to November 2nd. There's still a couple weeks, for signups, but don't wait too long because I want to be able to, lock in who I know is going, and I can kind of develop a little bit of a program of like who's going to go hiking with us, or what meals, if you want to join, which ones to go for. So if you're potentially interested in doing that, go to drtwyman.com/retreat. There's just a quick Google form that you can fill out just to give us contact information, and I'll send you an email that gives you more information about how to book a Canyon Ranch experience. I don't take any fee for this. You just pay your room and board essentially to the Canyon Ranch directly. And then lastly, housekeeping was, I do have Apollo Cardiology's birthday, that was actually last Friday, so a couple days post, but 6 years in practice. So I will be adding more and more information about what's going to go forward with the practice in my school group. Heart Attack Proof is the name of the group. It's on School, SKOOL. Right now there's a 7-day free trial if you're ever interested in signing up. I'm releasing some longer form videos there. There's a poll right now that people want me to do a video about nutrition, so I will probably give my 2 cents on how I think about nutrition that I usually give to only my patients one-on-one when I'm working with them. But that's where that information will be in the school group. So if you're interested in that, school.com, Heart Attack Proof. So with that out of the way, we'll jump into the questions. So first question up tonight, somebody's giving some stats, depends on what trial you look at, but approximately 1% absolute risk reduction for cardiovascular events with statins for primary prevention. What are my thoughts? So the real question is, what is true primary prevention? So start with secondary. That's easy. Secondary prevention is you've already had a heart attack, a stroke, a stent, you've had your chest opened up, and you've had bypass surgery. Those patients should be offered statins because it significantly reduces their risk of having another event. Patients who are primary prevention are another story. Never had a cardiac event. But many patients are, I would consider, 1.5. They've never had an event, but if they do the testing that we do at our office, where we're looking for endothelial dysfunction, vascular inflammation, soft plaque, and hard plaque, you're often going to find plaque in people who are asymptomatic. Are those people truly primary prevention? Not anymore. But they've not yet had an event, so probably start treating them as such. While it's true that statins as a monotherapy are not that impressive at lowering cardiovascular events, they do have some ability to stabilize plaque, and plaque regression is possible. So you're trying to grab all the low-hanging fruit that you can. You have to optimize the endothelial function and the glycocalyx. You have to keep oxidative stress and inflammation low. Got to keep the lipoproteins in check, generally less than the 20th percentile. Got to be metabolically healthy with no evidence of insulin resistance. There's a lot of levers you got to pull on to reduce the risk of plaque, and statins are just one part of that equation for some individuals. Can a person produce too much nitric oxide, and can it be produced in unwanted areas? So without taking exogenous sources, no, generally you're not going to be able to do too much. Now if you take phosphodiesterase inhibitors and throw on a bunch of nitric oxide promoting supplements, yeah, you can get your blood pressure low enough that you're lightheaded, dizzy, and potentially passing out. But usually think about 3 main ways people would optimize nitric oxide. Main way is you're exercising. Blood's flowing across your glycocalyx, which is the protective gel coat that lines your arteries, and the underlying endothelium releases nitric oxide. Next way is when you eat foods rich in nitrates. Those are mostly your green leafy vegetables, kale, spinach, arugula, also beets if you'll eat them. If you have healthy oral microbiome, the microbiome will break down those nitrates into nitrites. Those nitrites, once they're swallowed, will ultimately become nitric oxide in your stomach if you have stomach acid. And the third way that people usually release nitric oxide is when they're out in the sun, getting exposed to UVA spectrum sunlight. The UVA liberates nitrates from the dermal pools. So on occasion, if you out in the sun, vasodilating, you're popping a bunch of nitric oxide supplements, you might get your blood pressure low enough that you're lightheaded or dizzy. Please share my thoughts regarding statins not adequately studied in women. This was an issue in the past. I don't think it's so much currently. My friend Dr. Lyon had the woman who's in charge of the UCLA Women's Health Cardiology program, and they talked about this issue, is that for many years women were not represented in the trials because of the concern of what had happened with thalidomide many years ago. Thalidomide was a medication reported to help with morning sickness, but it was used in women without any studies before being released, and patients who had taken thalidomide had unfortunate side effects where the children had malformed limbs. So that obviously spooked many people, and women were taken out of many trials if they were childbearing age, and so they just studied men for often many, many years. But women are not the same as men. Certain medicines work very similar. Some of them are slightly different. So they weren't necessarily studied, but doesn't mean that statins, ezetimibe, PCSK9 inhibitors, and Nexletol will work for those individuals. So, if you do proper testing, look at vascular inflammation, look for endothelial dysfunction. You can do genetic testing if you need to. You can figure out which medications will generally work best for people. But that's a good point. Women are significantly more likely to die of heart disease than they are breast cancer. Well, breast cancer is unfortunate. As Willie Sutton said, why do people rob banks? Because that's where the money's at. So if you're betting, you may have cardiovascular disease. Make sure you don't. If you don't, okay, manage your other risk factors. But if you do, treat it aggressively. Next question up. The risk reward with ezetimibe if it decreases absorption but increases production. So this question would be from somebody who's already previously had a Boston Heart Lab panel. Boston Heart Lab does a test called the cholesterol balance test. It will look at if you're a hyperproducer of sterols, meaning your liver is just cranking out a lot of cholesterol, or is it more of an issue with the gut reabsorbing cholesterol, the hyperabsorbers. So approximately 20% of the population is a hyperabsorber of cholesterol. Think of it as a backed up drain, and the cholesterol is backing up into the liver. Not necessarily that way, but just make it simple for people to understand some of the basics. But if you take ezetimibe, often the body will compensate by increasing enzymes that produce more sterols. So it's a very expected side effect in some individuals. So sometimes you need to use something that lowers HMG reductase, be that red yeast rice, bergamot, statins, or if can't tolerate it, then bempedoic acid. But it's not a deal breaker. People start being a hyperproducer of ezetimibe. You're using it to lower lipoproteins, and use whatever works for that individual. 2 more questions pre-submitted, so thank you guys for those questions. Do mouth nitric oxide test strips give indication of nitric oxide in the EGX or endothelial glycocalyx? Not directly. So there are no tests that directly look at the endothelial glycocalyx. There are companies that are working on optical imaging of the sublingual blood vessels, the blood vessels in your mouth. It's still debatable. Is that exactly what's going on in your coronary arteries or your carotid arteries? So at this point, you can't directly visualize the glycocalyx. You can only really look at downstream effects, things that affect the endothelium. So do you have issues with nitric oxide? Or do you have microalbuminuria on testing? Do you have high uric acid, high homocysteine? There's a lot of blood testing can point towards, do you have a dysfunctional glycocalyx? Or the functional testing, which is preferred way. Pulse wave velocity testing, central blood pressure, the endopat, which we have at Apollo Cardiology, tells us how much arteries can release nitric oxide when they're under stress. Ideally, arteries should triple or quadruple in those times. The test strips just tells, do you have an oral microbiome that if you were provided nitrates, could you convert those things into nitric oxide? So it's twofold. Do you have a healthy oral microbiome, and are you putting in nitrates to begin with? So it's one part of the toolkit. But if you have an oral infection, they can falsely make those test strips positive. So you can't put all your faith in just one test strip. And last pre-submitted question, does low blood pressure affect your heart? It may. And what is too low? Are you symptomatic? Are you lightheaded, dizzy, passing out? Are you having perfusion issues where your kidneys are failing, your liver is failing? This is more common when people have infections or they're very sick in the hospital with cardiogenic shock. People as an outpatient are going to have this problem. But typically low blood pressure as an outpatient, it's going to be demonstrated by you're okay when you're sitting there on the couch or the bed, but when you stand up, start seeing stars. You want to check your blood pressure then while you're sitting, get a blood pressure, then stand up for 3 minutes, check your blood pressure while standing, and see does your blood pressure significantly drop while standing. So if your systolic blood pressure drops 20 points upon standing, so example, your blood pressure is 120/80 while sitting, but it drops to 100/80 while standing, you're orthostatic. So may need more hydration, may need compression stockings, possibly need more sodium in your diet to make you hold on to more water. So if you're symptomatic, then yes, you can have too low blood pressure that could affect the heart. All right, so those were the pre-submitted questions. We'll see if there's any popping up in the comments. I don't understand what this question is. Is the cells considered the second heart? I don't know what that means. If you have a little more information, just drop it in the comments, please. Okay. So somebody's just saying thank you for the lives. You're very welcome. I enjoy doing these. Question, what causes high uric acid? So uric acid is something that is filtered out of the kidneys. When the levels get high, the uric acid may crystallize. This can contribute to gout, which is a painful arthritis. So if your big toe is red hot and swollen, possibly it may be high uric acid driving that process. But typically what drives high uric acid is if you have kidney failure, if you're insulin resistant, if you're drinking or eating a lot of compounds that have a lot of fructose in it. So you can definitely do it with too much orange juice. Alcohol, particularly beer, typically raises up uric acid in some individuals. And then for some, it's protein. But I don't want people to be on a protein-sparing diet unless there's a very strong reason to be. So we'd look at more of metabolic markers of insulin resistance before we're saying cut back on protein for high uric acid. All right. So those are all the questions we got tonight. So maybe we'll just start doing these as more rapid fire styles. So always appreciate your guys' time and attention. I will have this live up on my YouTube channel, drtwyman.tv, within a couple of days. The old ones are all there that I'm now using AI to transcribe them and kind of put the comments in there so you can just search for the question that you're looking for. The longer form content, though, will be on YouTube, or it's going to be in my new school community, which is Heart Attack Proof on the school platform, SKOOL. Right now, there's a free 7-day trial if you're interested, but that's where I'm going to be doing longer form AMAs. I'll probably do some, show me your labs and I'll interpret them for you. I can't prescribe you anything, but I can say, okay, this is what I think is going on, and you need to work with your doctors, or if you're my patient, I want to share your information to help people. I'll walk you through what you can do to help other people understand what you're doing to optimize your cardiovascular risk factors. So again, that's the school community. So every Monday, 6 p.m. Central Time, I'll be back answering these questions. Look for my stories Monday morning. That's where you submit your questions. So hope you guys have a great week. Take care, get some sunlight, and see you next Monday.